bottom one, just out of laziness. I didn't want to have to stop by and adjust. And I've been about 6 months or a little longer. My hair's been falling out, but it's only the right side. And I'm getting well, I pressure points in the pain where I get so much pain in here, and even now I've got pain going from my ear, going straight up, and really my hip has been out of whack. I think I can't sleep on this side, and it's just all the way to my
your ankle.
yes.
Yeah.
That's something else.
Did they ever tell you that your wife is probably why all that happened?
Well, now I finally, when I told Shirley about it, she said, "You know what? I didn't dawn on me."
The most likely reason, probably not 100%, but the most likely reason why other things that you've tried don't work is because if your teeth aren't level to your brain's trying to keep the body level, and it does that by tightening muscles. And all your symptoms are caused by the muscle problems that are happening in your body.
You know what? Just 2 days ago, I was working out in the gym, and sure enough, I pulled a muscle right on this side. I'm thinking still, but now I knew what it was because Shirley had mentioned, maybe it's because of the bite.
When your bite's off and your muscles under constant strain, then you go to use them, they're weak, they're easy to injure. It happens to a lot of athletes that don't have the right bite. Guys that are runners, 100-meter runners and all that, they pull their Achilles tendon. Most of those guys wouldn't pull their Achilles tendon if the bite was right. It sets their whole system up to be weak.
I have a real hard time. I use, there's like this rubber tube, and I use it to stretch, and my hamstrings are like bones. They just pop. Where they're so...
Because they're trying to balance your body. And I found that there's two things that set the body out of balance. One thing is the way the teeth meet. The other thing is if you've got feet that don't move right. The arches don't go right, or the bones out. But most of it comes out of the mouth. Once in a while it's out of the feet. So if you get your mouth right, I think that probably most of that will go away.
We normally don't have this type of weather, this cold weather, and I run in the mornings, and I couldn't run with I have to take my partials off because it got, I guess, so cold for my bum. I'm not used to this, where I just feel like shots, like needles, boom, boom, boom. So I found my holy cow, I just pulled it out, and then every morning I just run without it. So
You got it in now?
I've got it in
Take
there.
it off for a minute. You can put it back in.
Do you run with your mouth open?
No.
We do it on. Well, I'm gonna do some testing, and we'll see what shows up.
Okay.
We'll see if anything shows up. We'll know. First off, I'm gonna feel your joints up here and see what they're doing. Go ahead and open your mouth. Does you feel that click on that side? And open again. You got a ruler here?
Yes, we do. But the lady that has the ruler is not here. Shirley? Shirley, he needs a ruler, please. He needs a ruler.
If you feel her joints, you'll find out that she opens up, she gets about 2/3 way open, and this one pops. And so the disc is probably closed lock, all the way open to 2/3, and it pops on. Okay. Open and close a little bit now. Yeah. Now when you put your fingers in her ears, you guys probably know this, but I'll go over it. Put your fingers in her ears, and they open and close. Right in front of your fingers, you should just be able to feel the condyle going up and down, okay? If it goes past your finger, you automatically know that they're distal. Okay. If it goes past your finger and pushes up, they're distal and superior in the fossa. Anybody that's distal and superior in the fossa got problems. That get stiff up in there? Sore up up there?
Sides,
Huh?
on the sides.
On the sides, right in here?
Mhm.
Yeah, okay. So the temporalis is sore, and those muscles sore right there,
Very tight.
very tight. When you take your fingers and you run them across the SDMs, they should feel like a round inner tube. If you run your fingers across them, and you feel little strands, you know they're in tension. Okay, you probably know all that already. But then you go down, leave interscapulas. Are these sore all the time?
Real knotted all the time.
Does that hurt? Are they sore now?
They're real tight. They're sore. That bone hurts.
Now you feel their neck right here.
Mhm.
You using your thumbs?
With my thumbs, I'm feeling the vertebrae from T1, C7, T1. And she's got a ramrod neck, we call it, where C7, C6 are in. T1's out, and so her neck, instead of having it smooth, you get what they call the start of a dowager hump where it goes in, drops in, then goes up. Okay, so that's classic for an overclosed bite. Denture patients are all made overclosed because the theory is if you keep the teeth up to the right height, they can chew so hard they make their gums sore all the time. That's why when guys are taught in school to make dentures, you always make your dentures a little overclosed. And it's really, if I do anything, I make them open instead of overclosed.
So the C7 comes down, and
The
then
neck is supposed to come down to a nice curve like this. Her neck comes straight and then out. So C7 is located, is anterior, is located anterior.
C7 is anterior.
C7 at least, yeah. Then you feel right back of the corner of the jaw, you're looking and you feel the atlas. You see what the atlas is doing. You can feel that with your fingers. And her atlas is rotated a little bit to the right side and a little bit anterior. So her atlas, instead of sitting like this, is sitting like this. Just a little bit.
Okay.
This is all chronic muscle problems coming out of the teeth.
Mhm.
So now, if her atlas is sitting like this, then down here the lumbar 5 is going to sit like this. They balance one another. They always balance one another. What goes this way here on the top goes this way on the bottom. What goes this way on the top goes the opposite way on the bottom. That's why it always translates up and down the bottom.
Mhm.
Okay. Now, a guy, an osteopath back in the 30s, took a kid 16 years old who had a perfect bite. Took an x-ray of his back. It was straight as an arrow. He took a upper first molar in the incisal pit and put a filling in there just a little bit high so he could feel it when he bit. Had him in the next day and took an x-ray and he had a 2-inch scoliosis in his back. Okay, so he cut the filling off. Had him in the next day, took an x-ray and his back was straight. So they put the filling back in. Had him in the next day and took an x-ray and he had a 2-inch scoliosis in his back. He did it 3 times just to prove the point. One little discrepancy in the bite caused a 2-inch scoliosis in a kid that had a really perfect bite. So now what happens to a person that's 2 or 3 millimeters deficient in vertical, is missing a tooth or two, has balancing, cross tooth and cross arch balancing interferences? What is their back going to look like? You know, lordosis, like she's got a lordosis.
My patient always bounces out straight. I don't know about yours.
Well, I had a girl years ago. She was 14 years old. She rode competition horseback riding. And she went to the orthopedic surgeon, took an x-ray, and he says she's got spina bifida. She's got, her back is so bad we got to put a stainless steel rod from her neck to her hips and pull all her vertebrae straight. So her mother came in and said, "What do you think?" I said, "I wouldn't do that in 100 years." I said, "If you will let me do orthodontics, her back will be straight. She doesn't have spina bifida." She said, "Are you sure?" I said, "No, but I can about 94%. But spina bifida is really bad, and the stainless steel rod is really bad." She says, "Okay, I'll pay for it." So I finished her orthodontics, sent her in to the orthopedic surgeon, took a picture of her back, and it was straight as an arrow. Didn't have spina bifida. And she said, well, my dentist did that for me. And he said, oh, sure. I kicked her out of the office. First case of spontaneous healing of spina bifida he'd ever seen. Okay, so that's what you do for people. You get them right. Okay. So now you get sore right in here?
Yes.
Yeah, right in there. Are you sore in here or out here?
More in.
More in here. Yeah. When you bite down, you don't have your partial, and you get up here or do you get back here?
I think back.
Okay, back in the back here. Now I'm gonna test you, let's see. This chair goes
She'll help you.
Up and down, like over here, yeah. Put her up and back and raise, yeah, so we can test her. Yeah. Okay, now I'm gonna do a test, it's a muscle test, are you familiar with that?
Yes.
Okay, you're gonna cross your legs. I'm gonna do one with your arm this way first.
Are you right-handed or left-handed?
Left-handed.
So I'm gonna turn your thumb down, you're gonna keep your teeth apart. Okay. And you're gonna hold your arm straight. Hold your arm nice and straight. Okay. And you can test people this way and this way. And she goes weak, and I can, it's off and on switch. You go like this, and now you go like this, she's strong, so she's testable. So now we tested her, open again, and hold your arm. Okay, now bite your teeth together, and hold your arm. See, there's nothing, I mean, I'm pushing the same way. There's no strength there at all, okay? So now we're gonna see,
Shirley, Terrell,
this is,
several of those.
Yeah, that could be from, the vertical being off, or it could be because she's got an interference somewhere or both,
could be, yeah,
right?
yeah. If it's an vertical, if they bite straight down, most of the interferences aren't in play. It's only when they slide sideways a little bit that they're in play. Usually when they go that weak, when you close their bite, it's a vertical, usually. Not every time, but almost every time. But then you can test the lateral excursion and also. So first of all, we're gonna test and see if vertical makes a difference to her. And, let me see how you bite. Okay, now, you look in their mouth, you see where the lower anteriors hit on the uppers, right now? Okay, open. She's got about a 4 to 5 millimeter overbite on the lowers. So she bites almost to the extent of the centrals when she bites down. And I can tell you that very often, almost always, the centrals are where they belong. It might be tilted this way, but height-wise, the centrals are almost always where they belong. Once in a while they're off, but not very often.
You're talking about upper central.
Uppers. So now, and where should the bite be? Let me close your mouth. See, the bite should be, open, just a little bit. The bite should be about there and a little bit farther forward. Now look where she goes when she bites. Bite down now on your back teeth.
Right.
She goes up and slides back.
Right.
So you look at that, and it's almost a guarantee that the vertical's way up. Yeah. Over close from the time the teeth came in. She was had problems when she was a kid in school even. Stiff necks, headaches, or whatever, you know, perpetual problem. So now we're
How
gonna,
did you get her in that position where
I
you were
just
showing?
arbitrarily put her there.
Oh,
because
okay.
That's where the anterior teeth belong.
Okay.
And if I put it right where the anterior teeth belong arbitrarily, just let me close your mouth. And you put it there, you see the space between the posterior teeth, that's about how high her appliance is gonna have to be for her to be well, at least vertical. We don't know about yaw and all that, so we're gonna put this in over the first molars, and bite down. Okay, she's not quite, push your arm like that. still a little weak, open, and we're gonna test her another way here in a minute. And we're gonna do this first. And you know, when you're muscle testing, if you want a sensory response, hold your arm up here and bite your teeth together. If you want a sensory response, you push like this, hold your arm straight, and you push real quick. If you want an autonomic response, you start soft and you just gradually increase the pressure. That's an autonomic response. There's two different responses to kinesiologic testing. One's a sensory response, and the other is the autonomic system.
Sensor, you push real hard, or
You start
it's an
right away.
instant load.
You start
Okay.
right away with a good load and push. and
Speedy,
see if they're weak.
speedy
If
sensor.
you want autonomic response, you start real soft and just increase the pressure. You're seeing if the brain can keep up with it. That's not autonomic response. That's running the body. That's two different responses to the same kind of a test.
So what's the difference?
Well, a sensory is the immediate reflex response, just like if you put your finger on a hot plate and you jump. That's a sensory response right back to the spinal cord. You know.
So it's a reflex then?
It's a reflex response.
Okay, okay.
Yeah, sensory reflex response in the muscles rather than autonomic maintenance response. Autonomic system runs your body, or they would call that, you know. So you're giving the brain a time to think through the autonomic system and see if they can make that system work. So
Which one do you test for? Autonomic?
Yeah,
You test for an autonomic?
yeah, that's the one I like, because
Okay.
I want to know what the body, what the brain's trying to do to keep the body running.
Right.
Like that.
That's close.
Now we're getting closer. Put your arm up here, put your thumb, and hold your arm. See, she's still got little jerky blacks in there.
Her jaw's back a little.
It's back a ways, but we're not open enough yet. Her jaw's back because closed like this, the upper teeth are like this, the lower teeth fit too, and they slid back on the upper teeth, you know. It has to be that. If it's over closed, it's just the way the teeth meet, because she's got this anterior bite, it has to be distal. There's no
Yeah, but
place-
why did her anterior bite form like that in the first place?
What is what?
Why did her anterior teeth form,
Why
relate to
did
each
they-
other
why
like that
did
in
they
the
do
first
that,
place?
Ian?
Yeah.
Who knows?
Mama had that
It's an opinion. If you read Weston Price's work, the first generation of native people on the Western European diet, the front of the face doesn't develop. Blocked out cuspids, okay? When the front of the face doesn't develop, blocked out cuspid and the lower fit under it, then for the teeth to fit, the jaw has to slide back, and for the teeth to meet, the lower teeth don't erupt far.
But
I
you
believe
just said,
I believe it's a nutritional problem, why she developed this.
okay, so, but you just said that almost always the upper centrals come in right on
To the
target.
height. To the height, not the width and all that.
Oh, the clinical length of
Clinical
it. You're
length.
talking about the
Clinical-
vertical,
Yeah, but I'm talking about the whole front of the face now.
you're talking about the AP dimension
Yeah,
of
the
this.
whole front of
Ah,
the face
okay,
is
okay, okay.
underdeveloped.
Okay, okay,
The
okay.
height
So-
of the teeth is gonna be about right on, but the whole front of the face is underdeveloped.
Okay, so you're
That-
talking about
that's
the
my-
vertical eruption is correct on the
Yeah.
central, okay,
Yeah.
all right,
Almost always,
okay. Now, that makes sense because of the lip, yeah.
yeah. And whenever you see somebody who's got a crease when they close their mouth, they're overclosed.
Okay.
You can, I run around looking at people, they got a crease here and they got overdeveloped masters, and I feel sorry for them. They used to stop people on the street and they'd say, how long have you had headaches and neck aches? Well, for a long time. I said, I could solve that problem. They look at me and they run away.
You're too smart for them.
So I don't do that anymore.
Well, I'm your next patient. So there you go.
Okay, so now, see, she's open enough and she's got just about a millimeter overbite. Now slide your jaw forward just a little bit, not so far, just a little bit, right there. Now put your arm up there. And hold your arm, see it's right there. No matter how hard I push, it's right there.
So your lower jaw's a little more forward too.
Yeah, I moved it just a little bit, because that's what needs to go.
Runar, I had a patient yesterday who's got soreness in both shoulders and I couldn't test her.
Yeah.
What do you do in those cases?
I'm showing you another test right now, the way I usually test people. This is the way most people are familiar with
I
testing.
know, but-
And I always test people this way, but I do arm reflex testing is my final test on everybody. And I'm gonna show you that right now.
Okay.
This was developed by Hans Lechner, which is a German guy over in Munich.
Uh-huh.
And all this testing came out of Europe to begin with, and then it came over here. And he was started doing. Hans Lechner was probably the number one guy over there that did this. And so he does it all through the computers now. He has a computer loaded up with all the no-shows in it for people, and he just stands there with a computer next to him and touches them and finds everything that's wrong with them and how to treat them. He doesn't have to even touch them hardly any longer. But this was his original testing. Give me your hands over your head now. And relax your arms nice and relaxed, real floppy, and keep your mouth open so your teeth don't touch, and just keep your arms real floppy. Now you put people down here, and now you're not pulling their arms, you're feeling their muscles. And you bring them up here like this, and you're feeling their muscles. Just both muscles feel the same, and you see where their thumbs meet. Or you can pull them up and show where this meets. I like to see just where the thumbs meet. You don't grab the patient and squeeze them, because these are your acupuncture meridians right down here, and you're affecting all the internal organs. So you don't squeeze the wrist like this.
You mind doing that again? Doing,
Yeah,
go, start,
I'm
huh?
gonna do that, yeah.
Okay, just
So
start
you
down.
you grab them right back here, very lightly. You're not squeezing them, just enough to hold their
Mhm,
arms.
Right, right.
Some guys have heavy arms, you gotta do it a little tighter, but she's a lady, so, and you let them go floppy like that, you bring them up, and you're feeling the tension in their arms.
Okay.
You're verifying the tension, seeing where the thumbs are. Now bite your teeth together, and then we put her back down, okay, then we bring her up, and we're feeling the tension in her arms.
Okay.
This arm restricted. I don't have to look at it, I can feel the restriction, but I look, she went from here to here. Okay. In her bite. Okay.
This is what Louisa teaches
Huh?
so well, right? This is what Louisa teaches so well.
Yeah, Louisa,
William.
AMPM reference, Louisa Williams, that's what her deal is. And she tests people for illness, not necessarily the bite, but she tests the bite too, but she can tell what organ system we have problems with. And, we can go through a Neuralink system, it's kind of fun to do. Now bite down.
You're putting that at the first molar.
Put them on the first molars, and then she slides forward just a little bit. And now, just relax your arms, nice and relaxed. And now she's even. I can feel it. It just loose. You can feel the difference in the body. Okay. I'm not pulling her arms. I'm just very lightly, with a real light touch, finding out where her muscles want to go.
Now, if they already have a shoulder problem, like he was talking to a patient with, then you have to do
If they're
something else.
relaxed, their shoulder doesn't come into play usually, unless they've got a real injury in their shoulder. If it's bound up in the shoulder and the joint itself. But a muscle injury, you're telling them to relax her, you don't want the muscles to interplay there. So what's happening with the arm reflex test is that the mucopolysaccharides in the body, the cell arrangement, positive and negative in the cells, if the brain, if they bite down, the brain said, I can't deal with this bite. One side of the body, the charge in the cells will reverse. The positive, negative will reverse, and the muscles on one side will tighten. It's a neurologic response. Okay. So you hold it like that. Open. You hold her like this, and then you just bring her back nice and even. I'm not pulling her arms. If you start pulling the arm, the test doesn't work. And then bite down. And then just hold your arms nice and still. Then she comes up, I can feel it. I can feel this one start to pull, and this one start to lengthen. Okay. Now, I always like to check people. Bite your teeth together. We always like to check and see if the whole structure of the body is suffering from the mouth. So I like to check the leg length. And I put my fingers on the edge of the
Intermalalis.
the ankle bones there. Put them both on right on the edge. And look where there's where her bite is. You see?
What do you mean, there's what her bite is?
I mean that's where her leg is right now. Okay?
It's biting together?
That's where the teeth bit down.
So
Now,
her heels are off.
so her right left leg is short. It's almost a half-inch short. Now we're going to see if most of that just comes out of the bite, or if it's a real chiropractic cranial problem. So we put this in her bite down. Pull up on her neck a little bit. Relax these a little bit in that bite. And then we check her leg length again. And I do this with almost every patient. And I go like this, and I put my fingers on her, right on the edges there. And now we've corrected 2/3 of that leg length. So we know there's a direct correlation between her bite and her hips. If I had her really flat in that chair, I think they'd come out even. The hips can't. That chair's got to walk, they won't really release. But if I had her really flat in that chair, I'll bet you her legs would be even.
On a table or something.
Well, just if we just took that chair,
We can do it if you want to.
yeah, do that.
Uh,
I'm not familiar with chairs too well either. Those never, the girls do all that. Oh, there we go. And then lower, then we go this way a little bit, so she's pretty level. The chair, tilt the chair, and there's the tilt. Oh, it doesn't tilt, it doesn't tilt. Okay, just leave it like that. That's kind of got her unlocked. And, right down. We'll put this in there. Back down. See if that unlocked her a little better. Yeah, she's a little better. She's probably a couple 16ths off now. So we corrected, her leg length corrected probably that much. Okay, so we know there's a direct correlation between her bite, her hips, and then her back in between.
How much, I don't think the camera saw the amount you were showing.
Well, her legs corrected about this much. You know, she's still a little bit off. If we had her appliance and got it really balanced, and we don't know if the upper's really balanced, we know we're just doing the lower right now. So if the upper's really balanced and the lower with it, everything in her body probably going to straighten up. Okay. So now what we would do, we would take impressions, we pour the impressions up, and we'd mount them on the Aculiner, and we would make our appliance to that height. Okay, now, a lot of times, one side is higher than the other side, and so a lot of times I'll take a piece of paper and see, this tells me real quick if the
back up just 1
maxilla,
foot. Thank you.
this tells
That's
me
perfect.
real quick if the maxilla is off. If I get up to a height and she's still not testing real good, I'll put one side higher than the other. Right down. See, now I'm torquing the jaw, or actually changing the maxillary position. Give me your arms down. And just relax.
Nope.
Okay, she went worse. Put your arm up here this way. Just hold your thumb down. And hold your arm real good. See, now she's going weak. So now we know,
Not that side.
not that side on the maxilla. You know. So now we'll try the other side. Both, I'll do this one here. Not right, and then push your arm up there. Turn your thumb down, and hold your arm. She's better, but she still works, so I would say, she got just a little bit of a maxilla is probably rotated just a little bit up on the right side. And, I look at her mouth, it looks like looks that way in the mouth, I look straight down in the mouth, it looks that way. And if I stand up here and look right down, this side looks, you look at it, just look straight down, look at the right side.
But you didn't particularly find that with the paper.
Well, the paper tested her, she went out a little bit, I probably had too much on the right side.
So half that much on the right
Probably
side
had
might
that
do it.
much right side. So when I made the appliance, I probably adjusted, so she gets a little heavier on the right than the left, and then test her. I'd make the appliance to this height, or maybe a little higher, and then I would just trim the left side a little bit, and then come in and test her with it.
Okay.
Okay.
So how do you translate that paper index to a mountable?
On the
thing?
Aculiner, the only
Right.
instrument you
Well,
can do it on is the Aculiner.
No, we're just gonna take a bite record.
We're gonna-
Right, right, I wanna see how you take.
He's we're gonna do that.
This
You get it.
over the
This is
first,
it.
this is over the first molars. That's my
Yeah,
bite
yeah,
registration.
yeah, I know.
That's on the Aculiner, I can put her on the Aculiner. And if I'm gonna index a hard appliance, I can put her on the Aculiner and move her forward just a little bit, index it, and she'll go right there every time. With the soft appliances, she won't. We just make them that high.
Okay.
And we're doing an easy analysis. Right.
These patients are coming in off 1960, just wanting to get treatment, and they can sense it.
Okay. Yeah, okay. So we would
Did they
take,
get
I
their
would take
anesthetic first?
upper and lower,
Nitrous.
upper and lower impressions on there and mount them on, that's what we're gonna do, mount her on the Aculiner, we're gonna make an appliance for her. That's
But,
what- that-
but when you mount that, I know you mount the upper DHIP, what do you mount the lower with?
To this.
Just that?
No, he's gonna we're gonna do
We're gonna do
a bite record.
Yeah, but this is a
But no,
guide to the bite
this is guide.
record.
We're gonna do vanilla bite record.
Yeah, you're gonna take, I'm gonna take a,
Interior index.
like a silicone bite, so we
Yeah.
mount the lower, the upper, and I'm gonna raise her up on the Aculiner to this height.
Got it.
Is that what you mean?
I understand what
Yeah,
you're
yeah,
trying to do now,
yeah,
okay.
yeah.
You just didn't use
I'm
this
do- oh.
breaker roll.
Getting ahead of myself. Yeah, you take a bite relationship, so
Yeah.
you can mount the lower to the upper, and then you put it on the Aculiner and raise it up to this height.
Yeah, I see.
And that's where you finish your appliance.
So do you ever try to take the bite record with the paper in play? I mean,
No,
no.
I'll make an appliance, and if she's off, I'll put the appliance in, and I'll put the paper in, find out where she belongs, you know. And I'll take a bite registration in the appliance, and then put the paper thickness to change it.
Okay.
A lot of times I work with chiropractors, they send back a patient, she needs one paper thickness on the right, and 4 paper thicknesses on the left. This patient needs 6 on the right and nothing on the left, but she needs to come forward a 0.5 millimeter. That's what they send back to, I'm supposed to go to the mouth and do that.
Okay,
And then I send them back and they test them, then they send word back if that corrected.
okay.
And you can do that. And when you take a bite registration, you don't ever let the patient bite. You don't let them bite, because they're always in an acquired bite. Your jaw's gonna go where it wants to go, where it's programmed to go. So if you take a bite registration, you have to take what I call a neuromuscular bite. You gotta take the patient open, and you take the patient, put your finger, would you relax your jaw, let me close your jaw? I'm letting her jaw down, just let her relax it, she does that real good. And so, I say, now when I take the bite, I don't want you to use your muscles. The only thing that's gonna use for your bite is gonna be my fingers, okay? You understand that? So when I put something in there to take your bite, I want you to do just like that. And I don't want you to bite, I'm just gonna close your teeth together. And that's when I'm gonna take the bite. She cannot use her muscles. Okay? And you're not pushing her jaw back, and you're not forcing her jaw anywhere.
Would you do that again with your left hand not quite so much in the way?
Okay? Open. Now just relax your jaw. Just I look and see if they're relaxed. Let them relax real good. And I see if I can move her jaw, and I say, relax, don't use your muscles. I'm gonna touch your teeth together, but just relax. And I go to there, and that's it. I don't let them bite.
Do you have your other hand?
No, I'm just touching her fingers up there. Just keep her head from going this way.
Oh, I see, I see.
And I just let take the bite. That's why I always take bites. You never let the patient bite with their own muscles. If you take a bite, I don't care if you're doing crown and bridge, checking occlusion for filling, checking occlusion on a crown, anything you do, muscle. Okay?
Right, so they're traveling through space.
Shirley,
I'm just,
you have
I'm
vanilla
just
bite?
taking their jaw, and I'm just with a nice, all these muscles are relaxed, I'm just taking their jaw and tapping. If I got articulating paper, I put it on this side, and I say, relax your jaw, and I relax, and I'll just go. Just relax, and I'll just go like that.
You run into people who won't allow you to do that?
A lot of people won't, they just can't.
Yeah.
So I tell them, okay, I don't want you to bite hard. Once you get your teeth together, you're as soft as you can possibly do it.
Okay.
And then when you get them close together, just let me push on it. I don't want you crunching your teeth together, because they're always in a pattern. And the teeth are sensitive to about 1 or 2 microns. 1 or 2 thousandths of an inch is the tactile perception to the brain. I mean, that's nothing. And that's what they're sensitive to. When you're doing fillings or crowns or anything, that's what they're sensitive to. So if you let them bite, they're gonna fool you. Okay?
So you're gonna record this with her open,
And
just
then
about,
A lot of times, if they won't relax, if they can't relax, hey, come roll. If they won't relax for you, you take a cotton roll, and you put it over the first molar, and you say, close down a little bit. Now just stay on those cotton rolls for a few minutes. Don't squeeze on them, but just keep them in there for about 3 or 4 or 5 minutes, you know, like that. Let them stay in there like that. And then I tell them, when I take the cotton rolls out, I don't want you to let your teeth touch, okay? If I take these out, you can't touch your teeth, okay? You understand? Okay. And then I take them out, open, and I put my finger in there so they can't touch the teeth. Okay. Then I take these out, and I take my articulating paper and put it in, and I said, now let me close your teeth together, just relax. And a lot of people initially wouldn't let me close your mouth, will let me close your mouth now. Sometimes it takes 10 minutes. But then you can close, and then you look and you can see where the warpiece is. Before I got into TMJ work and did all this on the Aculine, that's who I used to adjust bites. I always put cotton rolls in there for 10 minutes and came in, put the paper in and touched, and then I could fine tune the bite. Now I put them in a soft appliance, what we call the diagnostic appliance. That's the one we're gonna make for her first. I let them wear it for a week, get their muscles relaxed, and initially I couldn't take a bite, but now I can, because they get their muscles relaxed. Now I can actually go in there, tap their teeth together, and I can adjust their occlusion properly. But if somebody comes in and they got occlusal interferences, and they haven't been wearing an appliance, if I adjust those out, I'm invariably gonna adjust them out in the wrong place. Because they've got an acquired bite to get around them. You've gotta get the muscles relaxed and get them into a bite. And then you can tell really where their balancing interferences are, or cross-tooth interferences are, cross-arch interferences are. You get all that out of them. You know?
But if you, let's say you're trying in a, new reconstructive case,
Yeah.
round houses,
Yeah.
and you put these in, and you use the same technique,
Yeah.
you sort of romance their mandible in its own path, not distalizing it, but romance it on their
Yeah.
own arc,
Yeah.
right? And you close and you hit into a high spot, don't they go into a reflex
But I'll
avoidance?
adjust that high spot and then I'll do it again.
Okay,
I'll adjust the
Okay.
high spot and I'll do it again.
okay,
And I'm looking for 4 centric stops on
Okay.
each side.
okay,
Dentures, reconstructing, 4 centric stops.
okay,
Okay.
okay.
That's the lingual cusp on the lower teeth hitting up in the fossa of the upper teeth. Simultaneously, 4 centric stops in the posterior, nothing in the front hitting. They got a problem if you just lightly tap their teeth together and they hit in the front. They got a real major problem in the muscle. And if they got a reconstruction case and they come into your office and they got a pocket on 14 and nothing else hits, you automatically know that it's in traumatic occlusion. But if you have them bite, everything will look just fine. But if you get them relaxed, get them into an appliance for a week or so, then bring them in and you can see why they got bone loss on 14.
Because they're hitting on
Yeah,
14.
and they've done it for years.
Okay.
But
But
they'll
if they-
fool you with their bite.
if the problem is 14 is too tall or hitting first,
Yeah.
how do you know that it's, the other teeth aren't too low and it's not the right one?
Well, you muscle test them and you arm weight flex them.
So you're taking the bite record and you're arcing them through the mandibular path. And if you have no stop, you're eyeballing on where the vertical is? Are you eyeballing, I mean, you don't have a definite endpoint, right? You're romancing this thing here.
Just in your case when it comes in. You
No,
mean?
no, I'm talking about taking this bite now.
This bite now.
Yeah.
No, I'm letting her bite go. I'm just gonna close your bite like that.
Yeah.
Then I'm gonna mount her on the AccuLiner, and then I'm gonna open the AccuLiner up to here, and I'm gonna make an appliance.
So I think if you take the bite, we'll understand.
We'll understand.
We'll get
Okay.
it.
We need someone to bite check with her. And I'm gonna set her up just at a little different angle. We're gonna
So
lay
in your
back.
office, do you have the patient lie supine, or do you have them sit upright,
When?
like in a barber chair?
When?
In your, I mean, when you're doing this procedure?
I got a little higher than
45
this.
degrees?
Little higher than this, but for diagnostic appliance. But hard appliance, final occlusions, anything like that, they're sitting up and standing up.
Okay, so they're in a barber chair-like position? Okay,
Yeah. And I check them sitting up and I check them standing.
okay.
Because a lot of
Yeah,
people will
right,
change
right,
standing.
right.
Take a big deep breath. What happens? The zygoma moves back and down. The whole fossa changes. Then have them exhale, all comes forward. Because the zygomatic arch goes like this and like this, like a rocking chair. Inhale, exhale, inhale, exhale, inhale, exhale. That's the way it works. But I wanna, so that's why I do everything in the most relaxed position I can get the patient. But when they're back, the jaw drops back, if everything's relaxed. When they're up, it goes into a more natural forms. So final adjusting occlusion is always sitting upright and then checking and standing. Yeah. But for the diagnostic appliance, I don't worry about that. I'm just trying to get them out of their major symptoms and prove that I can help them. This is not the final thing. This is just getting us to the point where we get the muscles relaxed, the system starts changing, starts regulating itself, and then we keep it balanced. And then we decide whether the patient wants to go farther, whether they can afford to go farther, or whether they just have to wear a diagnostic appliance at night. I got hundreds of people running around, they just wear their appliance at night. The clicking stopped, the neck loosened up, there's no pain. Sure, the bite isn't totally correct, but they got no symptoms. And they love it, as long as they wear their appliance at night. And so I start out 24 hours a day except for eating. Then I see what happens to the joint, I feel their joint, see if the clicking stops, see what happens to all the muscles. The muscles get better and they say, gee, I feel great. I say, okay, let's wean you back on this. They wean themselves back and they go back so far. They say, oh, if I leave it out too long, everything comes back. I said, oh, well, that's a different story. That's what we're trying to find out. That's why we call the initial appliance a diagnostic appliance. It's helping us determine diagnostically what they really need. So the original appliance, like for her, is going to be the diagnostic appliance. And we might change the diagnostic appliance. We might have to make it higher. We might have to make it lower. If they got a lot of clicking and closed lock in the joints, and you want to get rid of the clicking, you take the diagnostic appliance and make it a pivot appliance. Leave in the pivot appliance for a couple of weeks, see if you get rid of clicking and popping. And if you do, then you take the height of the pivot and you put it into the whole occlusion. Make another appliance to that height.
Soft?
Soft
Still
appliance to that
diagnostic,
height.
okay.
Balance that, and then you see how their symptoms go. Okay? We used to make these huge, great big pivot appliances, now I just make little ones, because all it takes is 1 or 2 millimeters. Make a regular appliance to make it 1 or 2 millimeters in the back, not these huge, big pivot things. And you get rid of the clicking and popping, and basically, if the disc has been out for over 6 months, you're probably not gonna capture it, except on a rare case. But it depends on how distal and posterior the bite is. If it's just been hanging out there and all of a sudden it pops out, I got a lot of patients, I put them in an appliance and they come back and they say, something's wrong. And I said, why? Well, it clicks all the time. I said, oh, that's great. Now the disc is going back where it belongs. They said, really? I said, yeah, it was locked out before, now we've captured it. It's clicking off now. Now we make you a little higher and it'll stay on. So we make them higher than their muscles want. We get the disc to stay on, then everything starts to heal, and then they gradually come down to neuromuscular balance. Now you get the disc capture, they're not going totally closed. You do that with the hard appliance. Then you bring those down to most people, if they've got discs that were locked out and clicking and they come back on, they're too high for their muscles. But even that, because they're level, they do fine. Not totally. And as soon as the joint heals a little bit, that takes 6 or 8 or 9 months, they come back down. Now you can get them into neuromuscular balance and they do really good. That's why I don't ever go into reconstructive dentistry in less than 18 months.
If you've helped their disc, if you've done disc work for them.
Yeah, if I've done this kind of work for them, and they've got problems, I keep them balanced for 18 months minimum. Some of them 3 years. Because I don't want to build everything in there, and then they come back 6 months later and say, oh, you got it wrong.
So what's the criteria to go from the soft splint to the hard splint? When they're not clicking anymore, or?
Symptoms.
Okay.
Basic symptoms. If they wear a soft appliance for a week or 2 or 3, they come in and I say, well, when you take that out, after 2 weeks they're weaning it back. But I said, even if you've worn it for 2 weeks, I said, now take your appliance out, and then I want to touch your teeth together. Where do they touch? They said, oh, the only thing that's touching are my 2 front teeth. And I look, they're open 2 or 3 millimeters in the back. I said, well, now get your teeth together. And they go, my teeth won't go together. I can't get my back teeth together. I said, well, you got to go to a hard appliance.
Okay.
Because you're never going to be well. If you're that bad, you're never going to be well until we get you something 24 hours a day for that vertical. But if all their symptoms are gone, and they've got maybe a millimeter or 1 to 2 millimeter soft appliance, diagnostic appliance in there, I take it out and I say, get your teeth out, and they go, oh yeah, they go together. I said, good. You're probably going to get by just wearing that thing at night. That's all I got to do for you. Unless you want to spend a lot of money, pay me a lot of money and do a whole three-mouth reconstruction, I'll be glad to do that. And they said, no, I don't think so. I said, well, I can do that, but you probably won't need it if all you're interested in is most of your symptoms being gone all the time. You know?
Okay.
They say, fine. If they're 25 years old, I say, you're going to have ortho, or your device got to be built up. If they're 65 years old, I said, you know, if you don't mind wearing that at night, that's going to do you for 20 or 25 years. So what's the problem? They say, I'd like it that way. I'll just keep it.
Okay.
But once in a while they come back in and they say, after 4 or 5 years, they say, you know, I'm tired of wearing this appliance. What can we do? And I do composite buildups on your teeth, or whatever, you know, whatever has to be done, and put them there. And then they say, oh, good, I feel good now. That's kind of the work. Where the bite is and what you can do with it, and it's up to your
So
brain.
if they have a large posterior open bite, they go to a hard splint?
Yeah.
Okay.
You're not gonna make them better. You're not gonna get all this torque in their spine and all that without it.
Right.
Yeah.
Okay. So the deeper the original overbite to begin with, the more posterior open bite you can expect.
So let's do this. Let's go ahead and do the bite.
Yeah, okay. Okay, good. I'm gonna tilt her up at about 45, so I can not have them fight back. Because we're gonna wear this, they're in between laying down and standing up all the time with this diagnostic appliance, so I put them at about a 45-degree angle. Yeah, about like that. Okay. So now, when I put this, I'm gonna put this, put this blue stuff on your teeth, and when I put it on there, I want to close your teeth, but again, I don't want you to do your muscles. I want you to relax as best you can. Okay, close a little bit, right there, nice and relaxed.
And that's Blue Moose?
Yes.
That's a brand of it, Patterson's Blue Moose.
Okay, you can take that. Just relax a little bit.
Most expensive.
Just relax. I'm gonna hold your feet together. I don't want you to bite, just relax your muscles, nice and relaxed, I'm just gonna hold your teeth like that, that's why I take a bite. I don't want you to squeeze your muscles.
But the
at
teeth
all.
are touching.
I've got it up, I can feel the teeth touching. So I take all my bites.
They're still in their all-centric occlusion.
They're not now. Not if they didn't use their muscles.
Okay. So they're probably
They're in the
leaning
same-
on
they're in the
something.
same vertical,
Yeah,
but they're not in their acquired bite.
all right.
Maybe a little, because you don't really get the muscle totally relaxed, but they're real close.
Okay.
So with your Post-its, you're gonna know what vertical dimension to be open.
Yeah,
But you're still gonna guess about how much forward?
yeah. Well, in the diagnostic, I don't guess about four, I don't care about that, because it's gonna be flat. I'm gonna let their muscles put their mandible where they want the mandible to go.
Okay.
I'm gonna get all this muscle tension out, let the muscle move that mandible. Her mandible's being forced by her teeth to go where the teeth want it, and
Right.
that's not what her muscles want. So when I
Right.
put the diagnostic flat, it's not indented and all that, they're not chewing with it, you know, but it's in there and the muscles can do anything they want. Now, when they take it out, one tooth yet, or two teeth yet. So every time they chew, they go back into that old pathologic bite, you know, then they
Yeah.
put the appliance back in, and then they gotta shift back out. So you're going back and forth, you know, but if they wear that appliance 24 hours a day except for chewing, everything, the muscles, their neck, their back, everything relaxes enough that a little bit of time they're eating does not send their system into orbit. Their vertebrae are getting back to where they belong. All the torsions in their head, their dura, and their hips is all starting to correct. And that little bit of time they're chewing doesn't do them in. Unless they're really overclosed vertically.
That's it.
Okay, and then they'll come back and they'll tell you, every time I eat, I get a headache. You gotta have a hard appliance, you gotta have an eating appliance, you gotta eat it, you gotta have something in there to eat. So, every time I eat, afterwards I got a stiff neck.
Okay, so she has her appliance in,
Partial.
her partial's in.
That's okay.
Is that covering her incisor
I
papilla?
closed her up, I pushed her closed, and, oh, I didn't get this real well, but I think probably when I pushed her closed, the only place she hit was right up in here somewhere, or right back here. But we're gonna mount her to that, and then we're gonna change the Acculiner to the height of that paper. Then we're gonna make the appliance and we're gonna put it in. Okay. And then we're gonna test her and find out what happens to her. We're gonna let her walk around the room, check her legs, check her vertical and all that, see what happens to her. And then recheck the bite again with the diagnostic appliance. Then we're gonna let her go for a week. Then we're gonna come out and see what happened to the diagnostic appliance, where it's hitting. Always when you check the diagnostic appliance, you don't let them bite. You put the paper and you close the mouth on it so you know where it hits. And you level that out. And then you know within 3 weeks whether they gotta go to a hard appliance, heating appliance.
They eat with a hard appliance.
Yeah, if you go to that, they have to eat with it. They don't like it, but they have to eat with it. If they won't, they say, I can't, I say, well, you're never gonna get well, it's your choice, I don't care. It's your choice.
So can you substitute that hard appliance with composite builder?
Yep,
Okay.
if you wanna do something like that, that's great. But most people come in, unless they're really young, they come in and they got porcelain, gold crowns, and you can't bond to it. So you're stuck with a hard appliance, or do all the crowns over.
And you still want them to wear the hard appliance for a while before you do the crown also?
18 months,
Really?
at least, minimum, that's minimum.
Is this the bite material you use for the?
This stuff, well, I use a yellow bite check material that's a little softer than that.
Yeah, that's what I was gonna ask you, this is,
This-
what's the hardness?
I don't know what that is, but the yellow stuff is even softer when you put it in. And,
Oh, but when it's hard,
is covering her incisor papilla. So.
Oh, is it? Okay. So we gotta take it out to take the impression.
I think so. And, yeah, and
Yeah,
the,
yeah, we gotta, so she's got this appliance in here. What's this material? Valplast? Another thing I always do, you wanna take your appliance out? Another thing I always do with patients is, I take their plants out, and I test their arm length, keep their mouth open. I test their arm length. When you come in with the plants, I test their arm length. And then I put your plants in here. And I test their arm length. Because I want to know if they're reacting to that plants, the material in that plant. She's fine. You know. And I keep a little, mercury stuff around, and I put that on. I keep other composites in, and I test them, and I show them what happens to them. So now you can take an impression. You want me to take the impression?
Yeah.
Okay. You got that stuff? You got that mixer?
No, I didn't.
Yeah, I have a mixer. She's right there. She's the best.
On the dishwasher.
He can't believe that I don't have an alginate mixer.
Yeah. Well, I do dozens of impressions a week. And so I don't wanna mix that stuff by hand, so I got an alginate mixer. It takes about 10 seconds. That looks like it'll fit. And depending on
You
what I
still
do.
use alginate, not the alginate substitute.
Huh?
You still use alginate
Yeah.
instead of the silicone substitute?
No, I use an alginate. I don't know what it is. That's enough. You don't need more.
It's
You got
pre-mixed.
it all mixed up. See, I use just enough alginate, and I don't do pre-measures, so I can mix it to the thickness I want. Usually if we pre-measure, it's either too thick or too thin, and usually too thin. So I just keep the stuff in, we order, pill containers, about so big around, about that high, and we keep 1, 2, and 3 mixed alginates in there,
Which brand do you like?
alginate? I don't know it. I don't know this kind of thing. I take all final impressions with silicone, so I don't take final impressions with alginate. I use Accu-Gel to take final impressions for partials often, or and get my initial final impression for dentures with the Accu-Gel, which is your pink and your white material. Takes super accurate impressions. Yeah, see, that's too thick. I would never mix it myself that thick.
Really?
Never, yeah. I could get an impression with that. You load that up there, but that's about twice as thick as I would ever use an alginate.
Really?
Yeah.
Keep it off
Many
the-
nose into the throat isn't a
Keep it
problem.
off the palate, please.
Yeah, big problem.
If they're wrong, right? Yeah.
Yeah. But that'll be good enough. We can get her teeth probably. Load that up in the back a lot
You
more.
want more? Okay.
Gotta get a lot more in the back. Next time I'll mix one, and I'll show you how I mix it.
Okay.
So you wanna capture the notches back there, right?
Yes,
Yeah.
I gotta have the notches, so you gotta have more in the back.
Yeah.
You gotta have a lot of material back there. Okay, and so, I hope you gag. Do you have a problem with gagging?
No.
Okay, there's gonna be a lot of material in there. Breathe through your nose, relax your tongue, and you'll be fine. Now put the material in there. And just relax and breathe through your nose. And then close your jaw, almost touching the tray, but don't bite on it. If you have them keep their mouth wide open, you're gonna distort the impression. And it's not so bad on the upper, but if you do a partial impression or a hard appliance or anything with the bite held wide open, it's never gonna fit. 'Cause that lower jaw is gonna, like this, you know. And if you take the patient like this with the jaw wide open, you're not gonna get the hamular notches right. You gotta have it relaxed. And a lot of times if the, second molars are real long, I build up the tray with wax, put wax in the back of the tray, and then I put it in the tray and I push it up there so I see the impression of the hamular notches in the wax. And I'll take my thumb and just pull it out of the way a little bit. And then I use alginate that's about twice this thick, and I put it in there, and then I get a real good impression.
I misunderstood. I thought you had it thinner than this.
Thicker.
I was gonna say, it's gonna just run.
Yeah. Yours is
Okay.
twice as thick as this.
Mine is twice as thick as that.
Okay.
I'm thicker.
I misunderstood, thank you.
That's what I
This is
heard
too
too.
thin, is what he was saying.
I told her it was too thin. That's pretty well set now. Open a little bit. Good. Now I'll take that out. Okay, now we got good angular notches in there. See that? Nice, and you look through here and through here,
Mhm,
you get,
yeah.
and you got the incisive develop. I don't care about this.
What a good
I want
patient.
the teeth and those two areas.
Excellent. No gagging.
See, if her
Okay.
face is dirty
There's a
though,
lot of
she's been
people
eating
that
the
have
icing.
They're gonna be jumping out of the chair on me almost, and so we take those people and we sit them up in the chair and push their head forward, and then you have them take their thumb on their middle finger and squeeze it till it hurts almost, and that'll stop the gag reflex.
Good.
Squeeze it like that, and it'll stop the gag reflex. And if I know they're gonna be a gagger, I'll tell the brain not to let them gag, and it works for about 10 minutes. I'll say, right across the squamous suture, I'll say, you don't wanna gag, do you? You don't wanna gag, do you? Tell me, no, okay. You're not gonna gag, tell me you're not
I'm
gonna
not
gag.
going to.
Okay. Then I have them take their hand, and I say, okay, you squeeze right there real hard, and then I take the impression. So I got their brain telling them not to gag, and then I got acupuncture reflex telling them not to gag, and they do real well.
So you have the
Middle finger,
on the,
this finger here I want.
yeah, thank you.
Right on the tip, right on the tip like that, see? Right on the tip like that. And if they don't squeeze hard enough, my assistant will take there and just jam her fingernail into their finger. Yeah, and if that doesn't stop it, my assistant will grab their hand real quick and take her fingernail and just jam it into the finger. And they'll make it through the impression.
And you're putting
Cracks
the,
the brain, doesn't
are you putting the pressure on the thumb or on the middle finger?
The tip of the middle finger.
Thumbnail into the.
Thumbnail
thumb-
into-
okay,
thumbnail
so I
think we did it was
into the-
backwards that way, wasn't it?
Thumbnail into the middle of the little finger.
I got you.
Yeah. And, then we're gonna do a lower,
You wanna mix this next one?
yeah. You want me to mix the next one?
Sure.
Okay, put some water in the cup, that's all, and then, just leave it in the cup. And then,
This is,
take one of those, pour it in here. So now we gotta spray it this way. Okay, try it next one.
you want it with the partial reflex?
Yeah, it's on the lower.
Oh, yes.
She got a
has
lower
a little
partial. Let me see what she got on the lower. Yeah, leave the partial in, because we took the impression that way, we're gonna make the appliance fit or partial. That fits okay?
You're gonna make her an upper.
Lower, lower, always a
Oh,
lower.
I said, okay.
Always a lower. I took Jack Hayden's course and went home all excited, we're gonna bring everybody down and forward with upper appliance, anterior displacement appliance. I did 37 patients, and 36 patients went into abject pain, were ready to kill me within a week. And I said, you know, maybe this upper appliance doesn't work real well for you, why don't we try a lower one? And they said, will you? And I said, okay. So I made them a lower appliance, they came back and said, I feel great. What did you do? This is so good.
So do we want her to have to wear her partial with the lower appliance? Do you want her?
Yeah, lower partial.
But if you want, when you haven't been wearing it because it hurts or because it's a nuisance or
It's been a nuisance. I just started wearing it last week when I came to get adjusted.
have you had discomfort with it?
A little bit I have. I had just talked to Shirley about coming back in and
Okay.
adjusting it.
Okay, we can actually do two appliances. I'll show you how to make one when we take the partial out and how to fill in the inside.
Okay.
If we take another bite with her partial out, we can make two of them for her, and we'll show you how to make them both ways.
Okay.
Yeah,
Nice.
that'll be great.
So now to fill this so we get it lower, we're gonna mix only so much of this. We're not gonna use all this stuff. That's about all we're gonna need. And so the way I mix it is, I've got a thing that spins, but I put a little bit in, mix it up.
That's actually plaster, right?
The spinner has a water dosing too? or
No,
you-
I had the water, but I could, Now you
You can-
see how thick that looks now?
That's like the Epijet.
Yeah.
You can blend
See how-
that in.
See how thick that looks
Right,
now?
right,
It's
right.
just maybe a touch thick, maybe just a drop or two. Okay. And so that's the thickness that I like my alginate.
So it doesn't drop off your spatula?
No.
Interesting.
And of course, if I have the alginate mixer, I can
Whip that up.
I can whip that out of the bowl, and the bowl is absolutely spotless clean when I get through. There's nothing in the bowl.
Because it's so thick.
No, because when I take it out of the bowl. And I try to train my assistants to do that, and then once in a while, they do okay. You see, this is all I need for the lower. I don't need all that excess material in there. Relax your lips for me. Stick your tongue up to the roof of your mouth. Now stick it out at me. Now relax it. We don't need all the borders in this. All we need is the teeth in this impression. Because the appliance are finished right to the surface.
So Shirley, I need another lower, same size. I got it, thank you.
And when I hold an appliance, I'm using no pressure. I seat the appliance and I hold it there. There's no pressure once you seat the appliance. You do not continue to press on these things. You get them where you want it and you hold them still. If you keep pressing, as that stuff sets, it will distort on you.
Are we talking about the impression you're taking now?
Impression. Every impression I take. Once I get the impression material where I want it, whether it's silicone or whether it's alginate or whatever, there's no pressure. For dentures and all that, I'm border trimming, but when I border trim, I'm putting no vertical pressure on the impression material.
Save some adjustment.
You want to get that in, that it's that, you don't want to get tissue distortion, especially over for a partial, for saddles or, like that, you want to get tissue distortion.
Where's that?
That's probably gonna come out here, right? See, that's all of it. See, now we got a real nice impression of the teeth, real good there. If the stuff is too thin, you always get little voids. I do that. So if I get it mixed right to the consistency I want, they always come out looking real nice like that. Okay, now we take your lower impression. We're gonna take a new bite registration with the lower, without that in.
We need another bike registration.
Yeah, so,
Gonna do that for the lower without their partial.
Shirley, I'll be perfect tomorrow as long as you have all that stuff out, where I know, I don't have to find it.
Yes, I have it for you.
She's got it all here.
She's gonna leave it just out. It's gonna be out.
You can tell them about the lady you had, what, this week, or what it was, or whatever it was that came in, it was.
After our last course?
Yeah.
Well, that was for you.
I want you to tell them.
For everybody.
I want you to tell them.
No, that's our secret.
You left-hander or just MBW?
Left-handed. Okay, yeah, just relax, you can relax, and just let me hold it, don't bite. Just let me touch it too. Yeah, thank you. I'm gonna hold that till it's set. I shouldn't have had a half a cup of coffee. I shouldn't have had a half a cup of coffee this morning.
Bathroom break?
That thing is shaking and that usually doesn't do that. Coffee will do that to you. One cup of coffee or half a cup of coffee will raise your blood pressure 20 to 40 points. If you don't drink it. You don't drink it all the time.
Yeah, I know it depletes all the magnesium.
all your minerals, not just magnesium, mostly magnesium, but all your minerals.
Yeah.
And the average person, if they're buying their food at IGA or Safeway or whatever, are getting 50% of the minerals it takes to keep them out of the hospital with a major life-threatening illness. Half the minerals to keep them out of that. Now, if you want to be healthy, you got to increase that by tenfold probably to get enough minerals in to really be healthy. And now people drink coffee, tea, they eat stuff with caffeine in it. The caffeine stops the kidney from its selective ability to keep minerals in the body. So now they're pumping the mineral out of the body, and they're getting half what it needs to keep from dying of a major illness. How's the public going to survive doing what they're doing? How are your patients going to survive unless you tell them what's going on?
I mean, didn't Seattle, isn't that where Starbucks
Yeah.
got started?
Yeah, absolutely.
We're a society that runs on caffeine.
What's that?
We're a society that runs on caffeine.
Oh yeah, we're drug addicts. We're drug addicts.
Yeah, Starbucks is the legal drug push.
Yeah.
That's the,
Because everybody's hooked on it.
it's the Microsoft multitasking syndrome.
Very, very smart business
Yeah,
model.
there's the bite without her. Yeah. Now we're gonna take a
Change the
noodle
addiction.
to that thickness. You saw how thick that was. That's probably enough right there to do it.
Okay.
And then you just pour the water until you get a nice, fairly stiff mix. Yeah, just pour it in and mix it, start
What
mixing
do
it.
you use actually?
Pour quite a bit to start with.
Oh, from Starbucks. Yeah, they,
You
you know,
mix
the
that and see what
decaf
it
is
looks like. Start
actually
mixing
more
that, see what it looks
addictive
like.
than the caffeinated ones at
Very.
Starbucks. They've got something
Good.
in
Nice
there.
stiff, yeah.
Oh, they gotta make sure they do it.
No, they're going to. Mm-hmm.
That's what you need. Yeah, I mean, and so why are they taking all this caffeine? Why are they drug addicts on caffeine? Can you guess? Yeah.
They say 'cause they need the boost to get the day started.
Why do they have to get the day started?
They were tired,
To
deficient.
overcome from the carbohydrates that
Deficient-
burned out the night
deficient
before.
in minerals in the first place.
And why are they deficient in all the
They're-
minerals?
they're
They're not
taking
getting
carbon.
it. What's the biggest problem?
They're autonomic.
They're all on sugar diets. If you cook anything well done, it's a sugar. If you eat canned meat, it's a sugar. If you fry your vegetables, it's a sugar. They're all on sugar diets, low mineral diets, and so they're energy deficient. So now they're drinking caffeine to pop their energy up. And it takes 24 hours to get rid of a coffee high, a caffeine high from coffee. But after 4 hours, their sugar level has dropped subnormal. They gotta do something to bring it back up. They're gonna have a donut and a cup of coffee and it spikes. And then about 2 hours later, it's subnormal. And it takes them 24 hours to recover. They never recover. They go home after work so tired they sit and watch the boob tube until they fall asleep on the couch and they go to bed. They got no energy to do anything.
So you're saying the cooked meat and vegetables are sugars?
That's all they are once they're cooked well done. You can stir fry them or steam them, but if you want to be healthy in any way, shape, or form, you gotta eat a significant amount of raw food every day. It's the only place you're gonna get enzyme. Your pancreas monitors what you eat, robs your body of enzymes, tweaks them a little bit to digest just the food you've eaten. Specifically for the food you just ate, only. And it's supplying the resources from all your cells, comes to the pancreas gland, and it tweaks it a little bit, and then it squirts it into your lower digestive tract, so you can absorb food. Your pancreas will secrete 2 or 3 times its weight in enzymes every day. You eat a lot. It can't produce all that stuff. It's robbing it from your body and tweaking it to digest the food. It just doesn't set protease down here to digest meat. It conjures up the protease to digest the kind of meat you just ate. Okay? And if you go to a smorgasbord and eat 20 foods, it's trying to make 20 different kinds of enzymes so you can live. It's a gymnastic impossibility for that to happen and be healthy.
How do I find out more about what you just said?
About,
Pancreas and all of this stuff.
well, I've been studying it for 38 years.
Well, where did you get the pancreas information from? 'Cause I find pancreas to be very misunderstood and understood.
Oh, absolutely. The doctors think it makes all those enzymes. Out of what?
I mean, this is a revelation, you know?
Yeah, I pick up information out of Colorado, and I made videotapes. I know, I gave Bill my videos last time. I wonder if he's watched them.
Oh, we want some videos.
I didn't bring any, I forgot to bring any with me this time, but I've got a series. Home remedies, sugars, digestion, proteins, fats and oils, enzymes and vitamins, and minerals on videotape. They're about an hour and 10. Did you
Yeah,
get some?
yeah, I like your one on sugar, and you get your mixer, and you're mixing up
Yeah.
raw food in one session, and then and all the desserts and the cupcakes and another, and cookies and.
Yeah. I made these for my patients because people do not know what food is.
That's right, they don't know how to eat.
They think what's in the grocery store is food, and there's very little bit of food down there.
That's right.
So I made a tapes. The whole series of tape is about what is food, how do you prepare it, and how do you eat it to be healthy. It's not vitamin therapy, it's not drug therapy, it's not take a pill to get better. It's what does food do, and how does it affect your body, how does your body operate, so that's how you're gonna get well. That's what the tapes are.
Wow, okay, I want those.
I'll mail them to you, if you let me, if you give me your address or whatever, I'll mail you some.
Bill, did you watch those videos?
Not all of them, Cliff, but thanks for asking.
Thanks
No,
for asking.
Not those videos.
Oh, no, I watched all of this, but I didn't watch those that you sent me.
Oh,
Did you watch the ones that I sent?
No, sir. Oh, no. But I took them out of the lab, though, before you came.
I got patients that absolutely love those things. I mean,
Oh, it's not about the tape. It's not about the DVDs.
Should I write videotapes
no,
on that?
I'll remember.
Okay, thank you.
I'll send you some. I'll bill you for them.
I'm gonna use Bill's, cause he has they still have cellophane on
Yeah,
them.
they still got cellophane. He's not gonna watch them.
So what do we need? We're finished with Carmen right now?
Right now to a maker appliance. Now we're gonna go back and she's probably got metal models poured in her.
She's
set
pouring them up right now.
Okay, they'll be set in 10 minutes.
Okay.
And then we can mount them. You guys certainly a nice patient.
Isn't she?
Could you?
You let us do all.
What's that?
How come you're here?
He's going to tell you.
Yeah,
Good question.
Oprah will be here.
I wanna know why.
Will she? That's great. Maybe I'll get a basket or something.
I trust that you're here because you think you or know you have some kind of a problem.
Yes.
What is the problem?
Well, I have a lot. My jaw is like perpetually tight, gives me tension kind of all over my face,
Do
and
you get headaches?
I
right
do
through
get
there?
headaches.
Okay.
My jaw clicks, although not as much as it used to, because I've started carrying my jaw forward so that it doesn't do that as much. So yeah, I was talking to Bill about it when we were in town for, what was it, Thanksgiving or something?
So I'm gonna check here, and just look at your bite first, see where your teeth are, see what I
Right.
think of it, just put your head back, you close your bite. Now, first of all, first thing I noticed, you look at his lip line right here. His lip is rolled out, he's got a big crease here. Okay, I could look at him across the room and say, I feel sorry for him, he's had neck and back problems forever. Okay. Now, another thing, look at here, look at these muscles right here. He's got this face that's narrow here, and round here, look at these muscles right here. These things get sore, don't they?
Yeah, they're sore right now.
Sore right now, see how overbuilt the masters are? Occlusal interferences, and mostly it causes vertical, because the worst thing you can do to a muscle is shorten its natural length and tell it to work. That'll fatigue a muscle and make a muscle sore than anything else you can do to it. If you take a muscle and stretch it out past its working length, and then put a pivot in there, past its normal working length, it can't generate enough muscle power to form a trigger point. It's so weak. So a lot of times we used to put these huge buildups on people that really had these masters that were just killing them, temporals that were just killing them. They'd take a we put a pivot back there about that high for just a day or two. It stops those, if they got real pain and super pain in these muscles, you know. I don't do that anymore because I just put them where the AR test is and tell them to take some extra magnesium and drink water properly, and they die down real fast. I had a guy in the other day, he's been wearing appliance for years, and he came in, he comes from Seattle, he came in and he said, like, I can't wear my appliance and I can't touch my teeth. Open your mouth. I went like this to his tooth and he went and jumped. I can't touch my tooth, so I can't wear my appliance. Without my appliance, I'm gone. You know? I thought, what are we gonna do for this guy? I said, well, he's that sensitive, and it just came up in the last couple of weeks. The only thing that would make them that sensitive is an infection of some kind. Probably the most infectious thing that could do that so fast would be a virus. So I said, what I'm going to do a block back here, posterior block with ozone, and see what happens to your tooth. Ozone kills viruses in 1/3000th of a second. So I gave him a posterior block, took the needle out, laid it down, and I said, well, open your mouth, let's see how short your tooth is. And he opened his mouth and I went and rubbed all over his tooth. He said, it doesn't hurt a bit, nothing hurts. Put his appliance in, oh yeah, it works fine. I checked the conclusion's right on. I said, well, I don't have to see you anymore.
So what's a posterior block with ozone?
Okay, let's, how are we gonna stay on task here? If our task is to move forward, let's no more questions. I'm gonna whistle or throw something at everybody or whatever.
Test you. You get sore in here all the time.
Yeah, I see a chiropractor at least every other week. Yeah.
Okay. You get sore in here. Now I take the people and I take my hands and I rub up the muscles. And I see if they have any knots in their neck. Kids, when you do this to them and the bites off, you roll over a little ball bearing. It feels just like they got ball bearings on their neck. And I roll up and I say, oh, you got really neck problems. And I look, I feel him and he's really heavy right here. I can't hardly get into the SCMs because they're so full in there. I can't palpate the normal muscles right. Because he's been in so much trauma there for so long. Then I always test back here, the longissimus dorsi, the Hicks, tops the hip, you get sore back here. Okay,
The nice hurts.
yeah, that's the attachment of the longissimus dorsi that attaches right across the crest of the ilium. It goes all over the flat of the back.
What's the longissimus?
Right here at the corner where you're, right in the corner there. And you test these people, and you say, is that hurt? And they say, ew. They'll jump out of the chair sometimes. Well, I know now they got a back and a hip problem and a leg problem for absolute sure. Okay. So then I feel the jaw. Go ahead and open. Okay, so you open as far as that. Is that as far as you can open? Okay. Both discs are locked out. He can't translate. Neither condyle translate. He rotates on it. No translation. So both discs have to be locked out. Open and close. Back down. Okay, when I feel it in there, you get clicking and popping, and they translate a little ways, but then they get locked. So either the disc is really worn down, flat, and it's a little bit there, or it's totally locked out. I don't know.
It used to click a lot more than it does.
Doesn't click any as much now.
Not hardly.
It's locked out all the way, huh?
It's in closed lock now. The disc pops forward, and I have a little chart in the office. I show people what's going on in the joint.
So the disc is forward on both sides?
Yeah. Yeah. So then I'll take him and I'll say, open your mouth, and now relax your jaw a little bit for me. I feel the condyle, and I'll see if I can move it. I can't move it any farther than he opens, so I'm pretty sure that it's locked out. And this one moves even less. So we're going to test him for, let's see,
What do you need?
one of these goes bad, this one.
This one is done.
Oh, that's good. So I'm going to test you. First of all, I'm going to test, no, you put it back up. That's good. Okay, that's good. Good. I'm going to muscle test you to see how your strength of your muscle is. I've also noticed you got a big crease here, so your shoulders are rolled forward. causes the shoulder to roll forward is usually an overclosed bite. Everything's tense through here. All these muscles are pulling, collapsing his whole chest. Hard on the heart, and hard on breathing. Okay, and then C1 and C2 are never in the right place when that happens. So then I go up and down, I feel up and down her neck. And again, he's got a big knob starting back here. He's real young and he's already starting and dowaging upward. C7 is forward.
He married into a kind of a crummy family, so that's another issue.
Yeah. His muscles are so overdeveloped, I can't even get into his atlas. Can't even feel it. Is it sore right down here? Digastric is sore because his jaw is back and it's in tension. He can't move right because he's back and he's locked. He can't move anywhere. You've got posterior interferences on the lingual cusp and upper second molars, I almost guarantee. Okay. After looking, I will guarantee it. If you test them and the diagnostic is that sore, and the external pterygoid, you go into the external pterygoid, goes a little bit, it's sore up there.
Oh, yeah.
Yeah, on fire. Okay, the external pterygoid is pulling, and the digastric's tight, so he can't go into lateral excursions. So he's overclosed and he can't go into lateral excursions. I look at his bite, he bites up underneath there, he's distalized. I know he's overclosed, he's got a crease here, he's caved in here, all the muscles are overdeveloped in here. So he's young and he's still trying to survive.
So you had ortho when?
Huh?
Had braces when?
I had braces, I guess when I was 13 or 14, and they try to put what they call jumpers on to push my jaw forward when I wore those braces.
Luckily, they didn't take his first molars out, first eyes out, so he can be corrected pretty good. Really hard to correct him if they slick their bicuspid. Yeah, I'm gonna test your arm here, muscle testing. I want you to turn your thumb down, I want you to keep your jaw open a little bit, and then just hold your arm straight. He's young and he's a strong guy. Now bite your teeth together. Now hold your arm straight. I didn't just go boom, I put pressure on it and increased it, and all of a sudden he just went flop. Okay. If he wasn't overclosed, he'd be able to maintain that. Like that.
Does Office Depot have those paint posters?
These are just 3x3 posters.
Oh, yeah.
You can get them anywhere, any stationery store. It's my favorite.
Or you can order from Patterson and
Yeah.
charge
I can
$10.
charge you $1 a pack and send them to you if you want.
They have
I
the,
think we're off snacks.
they have the pre-mixed version of the 3x3 punches. That way you waste at least half of it.
Runar's posters.
Yeah, I got a label on Runar's Post-it, and I could make a lot of money selling these things.
No, you don't call them post-its, you call them Runar, you know,
Runar
occlusal.
Runar.
That's right. They should- Absolutely.
Runar's dental
Good God.
Put your arm up there.
I like that.
Can I put him to where I think he belongs? Hold your arm. He's like a rock almost. Like that. Forward just a little bit. Right there. That's where I think he's really, really like a rock there. Okay, now I'm gonna test him another way. Who knows, maybe I think he was good, so he was good. Maybe my mind.
Yeah,
right. So give me your hands over your head, bend your elbows, bend your elbows. Okay, I'm gonna hold your arms, you're gonna relax them, just let them go floppy. Just like they're broken wings on a bird, totally floppy. Okay, good, and you're gonna keep your teeth open again, keep your teeth open, keep your arms really relaxed, I'm gonna pull them up over your head. Okay, see, I'm just feeling where his muscles, I'm just feeling his muscles. Now bite your teeth together. Now you gotta reset it. And just relax again. Just relax your muscles. There's where his muscles go. Go from there to there. That's big, big time.
It correlates with how far it's gonna be open.
If they're really bad, sometimes when you do muscle testing for mercury or composite, sometimes they'll shift a half inch or 3/4. If they shift 2 inches, Or totally gone for whatever it is. I've had people with mercury go clear down to here. From here clear down to here. It's so bad for them. I tested other people's mercury and there was no.
Now, when you test them for mercury, do you touch your mercury tooth or do you put a vial of mercury in
No,
their chest?
tester tube.
Huh?
Tester
You're
tube.
testing the
All
tube.
you're doing when you're testing is pointing out the problem to the brain.
But you've got both arms, so.
Okay, let's
you-
move forward on this exam here, guys. Thank you.
Now you're done? And move forward just a little, what they give you hands, both of them. Okay, and then just relax your arms down. Like that. Okay, see his arms are just flopping. Just flopping. Before you can feel it, this arm doesn't want to come back. You can just feel it. So, open. We're going to take a bite registration, and then we're going to take a bite. We're going to build him to this height. And see what happens to him. And while she's mixing the stuff, I'll talk.
You can,
So
no,
I
you, no, you
guess
have to do
what
the
you-
bite record. I'm sorry. You can't talk. You have to do the bite record.
Here's the bite. Oh, there it is.
Sorry.
Okay, you can't talk. Okay, now when I take the bite, I don't want you to use your muscles if you can relax enough to let me check the bite for you.
Uh-huh.
Okay. Let me see if we can just relax your jaw, just nice and relax. Don't let that be too
Do you have his trays?
Yeah, you do okay. That's what I want to do when I take your
I
bite.
like
I don't
that.
want you to bite with these muscles.
Okay.
I want you to relax it.
Yeah, go ahead and
Just a
start
little
mixing.
bit. Okay. And just relax. Nice and relax. Let me close your teeth till I touch. Don't bite, you just me touching. Okay, good. Okay.
So we're about 15 minutes into the appointment. Pretty good.
So you don't really care about the anterior, you just want the posterior.
Just posterior, that's all. I just want to know where the lower fits the upper this way, that's all. See, I get people in with boxing night guards, upper plastic, and they get all the way around, especially in the front, it's driving the back, and they go nuts. And I said, well, instead of making you a new appliance, why don't I just adjust this one to the right height and see how you do? And they'll get 60, 70, 80% better just by giving the right occlusion. I said, no, you're not. Eventually, we're going to have to make you another appliance, but we can use this one as our diagnostic appliance for right now. And they say, great. So I use that as a diagnostic appliance.
Go ahead and put it in, Shirley. Thank you.
Good, there it is. And you can see, hold up the light, you can see, we got him down. He's got it closed there, but, about where he is. If we had some articulating paper, I'd go in there and I'd show you the balancing interference he's got on his second molars and probably his first molars. But his biggest problem is over vertical, so I would never adjust this thing.
So you close them until you feel some contact.
Yeah,
Stop
when I'm
there.
taking the bite,
Yeah.
yeah, I just
Close them,
close
just feel
them.
the initial.
But you would
contact.
not, you would not adjust those posterior balancing
Actually,
interferences.
not, he needs vertical. We don't even know where they really are.
Right.
You do them now, they might be a millimeter in the wrong place. You do, then you
That's
get
what I
them
was trying
relaxed.
to say, but my question is that you can't go and start grinding on stuff, because that could be the good one.
Yeah.
The other ones could be too low.
Okay, we're gonna take it up and lower.
You see what I'm saying?
Oh yeah, I heard that question. I got it when you said it. It was good.
Like right now, my deal is like, sure, my bike would be better if I could ground this back cuspid. But it might be the good one. And everything else is off.
Then relax.
I guess your own parameters is how do you
I like those special trays.
How do you test with the posterior?
Piece of that's good.
I mean, that's kind of the answer. Where is things rest when you want to do the posterior?
Now, if people are really off, I had a gal in, she came in for an exam, and I looked at her,